Good afternoon and welcome. My name's Tim Poe. I'm Director of Telehealth with the UNC Cancer Network and the UNC Lineberger Comprehensive Cancer Center. Thank you so much for being here with us today for our Medical and Surgical Oncology lecture on July 25th, 2018. A few preliminaries and then we'll meet our guest and get started. To let you know, our email address is unccn@unc.edu. You can email questions and comments to us there. If you are having any technical difficulties, if the audio isn't clear or loud enough, other issues that you would like for us to address, please call us right away, 919-445-1000. We do have experts standing by who can help you with any technical issues today. We are all over the place. We're on the web at unccn.org. That's the best resource to find out information about all of our upcoming presentations, past presentations, our learning portal, etc. We're on Facebook, we're on Twitter, we're on YouTube, we're on LinkedIn. Please spread the word about these free educational lectures. And of course, today's are eligible for CME, CNE, and ASRT certification. With that in mind, I want to remind our audience about Poll Everywhere. So there are two ways you can answer questions via Poll Everywhere, and our presenter does have several questions for you today. You can go to pollev.com, pollev.com/UNCCN. You can do that with any browser, including a browser on a smartphone. You'll see the questions come up. You can answer those questions as they occur. And then at the end of today's presentation, we hope that you'll be asking questions of our presenter. So please keep those in mind and share those at the end. We have another way you can join us as well. If you have any phone with texting capabilities, you can just text the number 22333 and you do that in the to field, so the number 22333, and in the message field you'll put in UNCCN. Do that one time, you'll get a message back that says join, and then you can respond with the appropriate letters corresponding to the answers for the questions, and then at the end go ahead and please type in your questions and our presenter will answer as many of those as time allows. So we look forward to those at the end. All right, our question for today, colorectal cancer is the blank cause of cancer death for men and women in the U.S. And if you believe that it's the number 1 cause, you would put A, number 3 cause B, number 5 cause C, or number 7 cause D. So again, colorectal cancer is the blank cause of death for men and women in the U.S. And so you can start answering that now, and then we'll look at the live answer in just a moment. All right, with that in mind, and bear with me for a moment here, I do want to introduce our presenter, Dr. Michael Lee. Dr. Lee, welcome.
Thank you.
Great to have you here today. So let's see a little bit about you. You're a translational investigator in gastrointestinal cancers, particularly colorectal cancers, focusing on drug development design of early phase clinical trials of novel therapies.
Yes.
And a clinical researcher designing and writing clinical trials in patients with gastrointestinal cancers and designing correlative studies to determine biomarkers of susceptibility or resistance.
Yes.
Correct so far?
Yes.
Okay, good. And finally, I have here that you are also involved in preclinical research necessary for drug development and novel pathopsychologic discoveries. Or pathophysiologic discoveries.
Right.
All right, good. So I'm glad I got that right. So, and maybe one more thing about you. Tell us a little bit about your educational background.
Sure. So I actually have roots in Carolina. I went to medical school just down the road at, he who must not be named, our colleague too. And, I've traveled around a lot since then in my training. I did my residency up in Boston. At Brigham and Women's Hospital in internal medicine, and then I subsequently did a hematology oncology fellowship in Houston at the University of Texas and the Anderson Cancer Center. I've been on staff here at UNC for the last 3 years. I'm just thrilled to be back, and thank you so much for having me today.
Absolutely. We're glad to have you here. Let's take a look at that poll. I see a trend, pretty strong on number 3. How are they doing?
That is correct.
Good.
And we'll actually have a slide explaining this in a little bit more detail in a couple of minutes.
All right, very good. Well, if you haven't already joined our polling, you still have time to do that, and then Dr. Lee will have additional questions for you throughout the lecture. Disclosures: this activity has been planned and implemented under the sole supervision of the course directors in association with the UNC Office of Continuing Professional Development. Dr. Thomas Shea consults for Spectrum Pharma and receives research support from Millennium, Otsuka, GSK, BMS, Novartis, and Seattle Genetics. Dr. James Coggill, MD, and CPD staff have no relevant financial relationships with commercial interests as defined by the ACCME. The speaker, Michael Lee, MD, has no conflict of interest relevant to this presentation. And Dr. Lee, without further ado, novel molecularly targeted therapies and biomarkers in advanced colorectal cancer. And I'll turn over the controls to you, and feel free to use the mouse as a pointer if you wish as well.
Great, thank you so much.
All right, thank you.
So today we'll be discussing some of the underlying important clinical pathologic features describing the biology of colorectal cancer and using that to better understand some of the differences that may exist from patient to patient. We'll discuss several therapeutic options that are currently standard of care in the management of metastatic colorectal cancer. And then we'll describe biomarkers that can guide selection and personalization of therapies for patients, both kind of as current standard of care, and a few slides describing kind of up-and-coming, very promising biomarkers as well that may help select patients for particular therapies. So, per our initial polling question, we're all aware that colorectal cancer is a leading cause of cancer death in the United States. And when you break it down by men and women separately, it's the number 3 cause of death for each of the genders. And then when you actually pool them together, colorectal cancer is the second leading cause of death related to cancer. So it's a huge problem. I think we are all familiar that there is a significant amount of heterogeneity clinically amongst our patients. Some patients have, fairly indolent disease despite having metastatic disease, and some patients have much more rapidly progressive disease. And here we just break down in these pie charts a few ways we can break down some of these distinctions, and we'll go into this in the next few slides. So first, we're all aware that cancers can harbor a varying number of mutations within a number of oncogenic growth factor pathway proteins and genes, and that's certainly true in colorectal cancer. I think we all have probably heard of the importance of KRAS, NRAS, and BRAF oncogene mutations within colorectal cancer as something we should be testing for routinely, and I'll be talking a bit more about that later. But you can see, about 40 to 50% of patients are wild type, do not have a mutation in any of these 3 genes. About 40 to 50% will have a mutation present in either KRAS or NRAS, predominantly in KRAS, and about 5 to 10% have a mutation within BRAF as well. There's clearly a number of other oncogenes and tumor suppressor genes that are commonly mutated in colorectal cancer, including APC and TP53. Many of these are, at this point, not necessarily targetable or actionable, but I do think it underlies the biology of this disease. Next, I want to make the point that hypermutated status defines a key subgroup of colorectal cancers. It's about 15% of colorectal cancers. Actually, the majority of patients with colorectal cancer have tumors that are not hypermutated, as seen in orange in the pie chart. But we clearly know that the number of mutations is an important variable for us to think about, particularly in this era of immunotherapy. So on the right, you can see kind of early data from the Cancer Genome Atlas Network seminal publication describing the biology and genomics of colorectal cancer. And you can see among the 15% or so of patients who had hypermutated tumors, there's really an order of magnitude difference between the number of mutations that are present scattered throughout the genome versus those who do not have hypermutated tumors. As you'll see in this chart, most of these patients have tumors that are MSI-High or microsatellite unstable. Which is clearly the predominant and most important etiology of this hypermutated state. Microsatellites are a number of small, kind of 1 to 6 base pair repeat sequences that are scattered throughout the genome, and these are areas that are particularly prone to errors in the process of DNA replication. So normally there are very important mismatch repair mechanisms to proofread in the course of DNA replication to catch these errors before they are propagated into the daughter cells. However, deficiency of these mismatch repair protein mechanisms can result in consequent microsatellite instability, failure of these proofreading mechanisms, and a genome that is scattered with mutations. This can happen through three predominant ways. One is through a germline mutation that's present in one of the key mismatch repair proteins, which we're all familiar with as Lynch syndrome or hereditary non-polyposis colon cancer syndrome. The other mechanism this can arise is actually in sporadically arising colorectal cancers where they're really driven primarily by epigenetic silencing via promoter hypermethylation. And in this case, they specifically will usually hypermethylate one of the key mismatch repair gene promoters, MLH1, which results in microsatellite instability. This is most commonly seen in older women, typically with right-sided colorectal cancer primaries. And then there's a much smaller group of patients, but one that I think is important just to make you all aware of, that actually have a mutation, either somatic or germline, that's present within the proofreading domain of one of the DNA polymerase enzymes, such as POL-E or POL-D1. And this is relevant because, as you can see on the figure on the left, patients who have these POL-E mutations actually have an even higher rate of mutations present within their genome. Even higher than the MSI-High patients. These patients often, or usually, will return as apparently microsatellite stable based on current standard testing. So it is important, if you do happen to get this through a next-gen sequencing, or if you see someone who's microsatellite stable but has just an unusual number of mutations that are present, many of which may just be passenger mutations that are that aren't actually activating. But if you notice this, it's something that you should cross your mind. And this is relevant because generally we know that the greater number of mutations that are present within the genome, there's going to be a greater number of bizarre, never seen before by the body neoantigens that are consequently translated, abnormal proteins and peptides that result as a consequence of these mutations. And these can be recognized by the immune system and have a consequence of an increased lymphocytic infiltration into the tumor. So we can see on the figure on the right that the number of neoantigens is very clearly correlated with the overall lymphocytic reaction score, reflecting the degree of tumor-infiltrating lymphocytes that are present within colorectal cancers. And again, this is of importance in this modern era of immunotherapy, and we'll touch on that later. Just as a refresher, there are a couple of standard tests we frequently will order for assessing microsatellite instability or deficient mismatch repair. Those are considered generally synonymous, but reflect kind of the different tests we're using. So one method is by immunohistochemistry, where we perform staining for the four key mismatch repair proteins, MLH1, MSH2, MSH6, and PMS2. So the normal microsatellite stable state, you will see that there is intact nuclear staining of all four of these proteins, even within the tumor cells. However, in a microsatellite unstable tumor, you will see that there's loss of nuclear staining of at least one of these proteins within the tumor. So in the example in the picture on the below left, you can see that MLH1 and PMS2 do not have adequate or normal intact nuclear staining. So these are microsatellite unstable. The other way we commonly will assess for microsatellite instability is through polymerase chain reaction, or PCR, to assess whether there is an equal number of kind of microsatellite repeats in both normal and tumor tissue, using a 5 to 6 locus panel that's been validated. So in the example above, in a microsatellite stable tumor, you can see that there are no differences in the microsatellite repeats based on PCR between the normal up top and the tumor below. However, in the microsatellite unstable tumor, you can see that several of these loci have abnormal microsatellite repeat numbers in the tumor as opposed to the normal, because you can see kind of differences, different locations of the peaks in multiple loci. Now, I'll point out that generally there's a very high concordance between immunohistochemistry and PCR methodologies, over 95%. However, studies have shown that about 10-11% of patients who have microsatellite unstable tumors may have discordant results between PCR and IHC. This is often seen in the case of Lynch syndrome patients, where you may have, for example, a point mutation within one of these genes that doesn't necessarily abrogate the nuclear staining on immunohistochemistry, but is in fact inactivating of the function of the protein. And so if you do have a very high suspicion for Lynch syndrome, it is worthwhile to check for both of these to make sure it's not one of these cases. Increasingly, we're seeing next-generation sequencing to also infer the state of microsatellite stability or instability. There have been a number of publications and abstracts that have laid out kind of the validation for several specific panels. So on the left, you can see a validation for Sloan-Kettering specific sequencing panel, which showed over 99% concordance compared to with the sequencing determination versus standard of care IHC or PCR assessments. On the right, you can see a similar result for the Foundation 1 panel. At this point, NCCN consensus guidelines, which I think we're all familiar with, have concluded that testing for MSI microsatellite stability may be accomplished with a validated next-generation sequencing panel. I do want to stress that it's important to just be mindful kind of how the level of validation that your preferred panel has had. So if you're using one that's less common or more kind of new, I do think it's important that you're making sure that your results are in fact validated. But it is a convenient way because many of us are doing next generation sequencing nowadays, particularly for metastatic patients, to kind of get the information all at once. And all of these come together in kind of refining our understanding of the underlying carcinogenic mechanisms that define the development of colorectal cancers in the first place. I think many of us have learned from medical school or at other points of our education that there's this kind of traditionally taught sequence of events where you have progressive acquisition of abnormal mutations in the process of going from normal colonic epithelium through a precancerous adenoma to a full-blown malignant carcinoma. And while this is clearly a valuable model, it's not necessarily the best representation of all colorectal cancers. This conventional model probably best represents the majority of patients who have underlying chromosomal instability with a bizarre number of chromosomal losses and gains, where you can have, say, loss of function of the APC tumor suppressor, first contributing to the formation of an adenoma, and eventually with progressive chromosomal instability, loss of the tumor suppressor P53, and other mutations, it can develop into cancer, and that's seen on the bottom of this figure. However, we are increasingly learning that there is another subset of cancers that, rather than being driven primarily by chromosomal instability, is actually driven by epigenetic aberrations with hypermethylation of multiple promoters. And that can result in either microsatellite instability if one of the genes that is epigenetically silenced is MLH1, as I was alluding to before, or hypermethylation with microsatellite stability. We're increasingly learning that these are associated with different kinds of clinical features. For example, the hypermethylated tumors are much more prevalent in right-sided primary colorectal cancers as opposed to left-sided, and we'll touch a bit more on that later in our talk. But these are clearly underlying mechanisms, and while these aren't necessarily being tested for routinely at this point, I do think that these are important aspects that can help understand some of the differences we see among patients. So with that, let's start thinking about how we can apply this in actually affecting our cancer treatments. So let's review this case of a previously healthy 60-year-old man who presents after colonoscopy is performed for iron deficiency anemia. And this has shown a moderately differentiated adenocarcinoma in the ascending colon. He has no significant family history of colorectal cancers. Initial staging CT scans have unfortunately shown multiple bilobar liver metastases and peritoneal carcinomatosis. The patient has an excellent performance status with an ECOG performance status of 0. So based on current standard of care recommendations, which of the following tests is not recommended to send tumor tissue for? So if you can enter your results through Poll Everywhere. Is it A, a BRAF codon 600 mutation, B, assessment of microsatellite stability, C, PD-L1 immunohistochemistry, D, assessment of mutations in KRAS exons 2, 3, and 4, or E, assessment of NRAS mutations in exons 2, 3, and 4.
Great, and thank you all so much for submitting those answers. We'll wait just a few more seconds. If you haven't already submitted what you believe to be the answer, looks like we're starting to see a trend.
Yes.
All right, how are they doing, Dr. Lee?
Good. I think the majority is correct here. So at current, what we would recommend all of these except for PD-L1 immunohistochemistry. Obviously, this is an important test for many other kinds of malignancies, but for colorectal cancer, PD-L1 immunohistochemistry does not have a current standard role in guiding your therapy or really serving as a prognostic biomarker. So we performed the test that we just ordered. And again, this patient, as a refresher, with moderately differentiated adenocarcinoma of the ascending colon is found to have intact nuclear staining of MLH1, MSH2, MSH6, and PMS2 on immunohistochemistry. And we performed testing in KRAS and NRAS exons 2, 3, and 4, and BRAF codon 600, and we do not find any mutations present within any of these sites. So, recognizing that there are a variety of potential options, out of the choices that are listed here below, which of these following treatments would be the best first-line therapy for this patient with metastatic ascending colon cancer? Choice A, pembrolizumab. Choice B, FOLFIRI plus bevacizumab. Choice C, FOLFOX plus panitumumab. Choice D, CAPOX plus ziv aflibercept. And choice E, trifluridine plus tipiracil, also called Lonsurf.
All right, and waiting a few more seconds again. If you haven't had an opportunity to submit that answer, please go ahead and do that. Well, it looks like we've got 100% on B. How did they do?
That is exactly right. And I'm going to discuss some of the data. And some of you may be wondering, well, why isn't choice C appropriate? FOLFOX plus panitumumab or chemotherapy plus panitumumab. And we're going to discuss some of that kind of moving forward. So the first point to make is whenever you have a patient with a newly diagnosed metastatic colorectal cancer, the first thought that always crosses my mind is this patient potentially resectable? Do they have oligometastatic disease that is amenable to resection, typically in visceral organs such as liver, ideally, but also lung, that is amenable to resection? Because if that's the case, then we should be thinking about a multimodality approach. However, the case we described had a patient who clearly had unresectable disease with bilobar liver metastases and peritoneal carcinomatosis. So I think we're all familiar with the fact that our typical first-line chemotherapies in fit patients would be a chemotherapy backbone of fluoropyrimidine plus either oxaliplatin or irinotecan, combined with a biologic agent to give a maximum improvement in progression-free survival, and with many studies showing improvements in overall survival as well. So generally we choose the chemotherapy backbone just based on the, there's no one right or wrong answer when you choose the backbone. It's just based typically on side effect profiles. The biologic agent, there's been a lot of studies in the last few years that have described kind of selecting the optimal biologic agent, which we'll go over. One thing I'll just point out is that there is some literature recently just describing FOLFOXIRI plus or minus bevacizumab, an even more aggressive approach. And certainly this, in the TRIBE study, this did improve survival outcomes. So it's not, it's a reasonable thing to do, but in reality, it's probably reserved for certain circumstances, such as, in my preference, I tend to use it, say, in a very fit patient who has a BRAF mutation. I'm happy to answer any other questions about that if they come up. Starting with anti-angiogenic therapies, clearly these are an important class of agents that are used in colorectal cancers. And this figure lays out actually all of the anti-angiogenic therapies that are currently approved for use in colorectal cancer. So I think we're all familiar with bevacizumab, which is a monoclonal antibody that targets the vascular endothelial growth factor A, which is the most prevalent kind of pro-angiogenic ligand. And really is the only FDA-approved choice for an anti-angiogenic therapy to be used in the first line. These additional agents of zivaflibercept and ramucirumab are also approved in the second-line setting. Zivaflibercept is actually kind of a fusion receptor which serves as a decoy against several ligands, pro-angiogenic ligands. And ramucirumab is a monoclonal antibody that targets the type 2 VEGF receptor, which is the key receptor that mediates angiogenesis. And then regorafenib, as we're familiar with, is a small molecule tyrosine kinase inhibitor that inhibits multiple VEGF receptors along with other receptors, and is currently FDA approved for very refractory patients after exhausting most other lines of therapy. I'll talk a bit more about some of these the evidence for some of these antibody therapies. Just as a recap, the initial trial data has shown that adding first-line bevacizumab to multi-agent chemotherapy improves survival as compared to chemotherapy alone, although not every trial showed this result. So on the left is the seminal result that led to FDA approval, the AVF2107 trial, which showed that adding bevacizumab to the now old and not used chemotherapy regimen of IFL led to a significant improvement in overall survival, as seen up top, and in progression-free survival as well, as seen below. In sorting together the evidence for several of these trials, on the right we see a meta-analysis that was done of several studies, most of which included bevacizumab in the first-line setting, comparing bevacizumab plus chemotherapy versus chemotherapy alone. And the conclusion of this meta-analysis was that the addition of bevacizumab does in fact improve overall survival. So I think most of us do feel that in a patient who doesn't have contraindications, it is very reasonable to add bevacizumab to standard chemotherapy and recommended. There's also a role for second-line anti-angiogenic therapies. And this is the setting where you have multiple options, as I was laying out. This is just a quick summary of several of the trials that have formed the key base of evidence for second-line anti-angiogenic therapies. The top trial, the ML18147 trial, showed clearly that in patients who had gotten a first-line chemotherapy plus bevacizumab, you continue to see a survival benefit by continuing bevacizumab into the second line of therapy, with switching the chemotherapy backbone from an oxaliplatin-based to an irinotecan-based chemotherapy, or vice versa. The other two trials, the Valor trial for zivaflibercept and the RAISE trial for ramucirumab, looked at adding the anti-angiogenic antibody to second-line FOLFIRI after a first-line FOLFOX-based approach, and so are FDA approved specifically for that setting. You can actually see encouragingly that the hazard ratios for overall survival and progression-free survival are all pretty similar across the three trials, which is encouraging that we're seeing similar magnitude of benefit. But I will just point out that the NCCN consensus guidelines do recommend that bevacizumab be the preferred anti-angiogenic agent based on toxicity and or cost considerations. So the next question arises, among patients who have RAS wild-type colorectal cancers, what is the evidence base for adding anti-EGFR therapies? EGFR being the epidermal growth factor receptor. So just as a quick recap, this is a quick schematic of the EGFR signaling pathway. EGFR is an important receptor at the cell surface that binds to a number of ligands that are pro-mitogenic, pro-cell growth, and proliferation. So typically, binding a ligand to the receptor results in activation of a downstream signal transduction cascade mediated through KRAS and NRAS, and subsequently BRAF, MEK, and ERK. I highlighted here KRAS, NRAS, and BRAF because these are genes that are more commonly mutated within colorectal cancer and do play an important predictive biomarker for use of anti-EGFR therapies. You can imagine if you have an activating oncogenic mutation here at this level, that blocking up here is not going to be particularly helpful because you still have ongoing constitutive activation of the signaling pathway downstream. So mutations in KRAS most commonly occur within exon 2 in codons 12 and 13. The exact percentage may vary by study, but probably about 30 to 45% of patients do have a mutation that's present within KRAS codon 12 and 13. And, it's been about 10 years since we've recognized that the presence of a mutation in KRAS is, in fact, a predictive biomarker for resistance to anti-EGFR therapy. But our exact definition of a KRAS mutation has evolved over time, and I'm going to go over that with you all. So about 10 years ago, it first emerged that these most common mutations, that KRAS codon 12 and 13 in exon 2, are associated with resistance to anti-EGFR therapy. So this is data from a clinical trial of cetuximab monotherapy compared to best supportive care. And you can see in the graph on the bottom of the figure here that among patients who are deemed to have wild-type KRAS, not having a mutation in KRAS codons 12 or 13, cetuximab results in a significant improvement in overall survival and in progression-free survival. And among patients who had a mutation in exon 2 of KRAS, there was really no significant difference between best supportive care versus cetuximab monotherapy. And these similar kinds of studies have been shown in a number of contexts. So this is from the CRYSTAL trial of first-line FOLFIRI, randomized against FOLFIRI plus cetuximab. And here again, we can see in patients who are deemed wild-type in KRAS exon 2 that the addition of cetuximab to FOLFIRI resulted in a significant improvement in progression-free survival. Not necessarily in overall survival in this trial, and we'll discuss some more about why perhaps this definition of wild-type KRAS at that time was not necessarily optimal. One thing I'm going to quickly point out as an aside is that there has been chatter about whether a KRAS G13D mutation specifically may be more sensitive to anti-EGFR therapy. I think relatively recent data would conclude that that's not the case. It's a relevant and interesting question. I mean, I don't think, we wouldn't expect every mutation to have the same biochemical effect necessarily. So a codon 12 mutation versus a codon 13 mutation, biochemically it'd be reasonable to say would have different effects within the cell. And there were some retrospective studies that actually suggested that perhaps having a KRAS G13D mutation was that these mutations may not necessarily be as negative of a predictive value. However, I'll point out here that the ice cream study from 2016, which looked at patients which actually prospectively assigned patients with a G13D mutation to receive either cetuximab monotherapy or cetuximab plus irinotecan, really showed that there were no significant improvements with this treatment as compared to what you would expect in the best supportive care arm of the cetuximab monotherapy trial that I presented a few slides ago. And there was a 0% response rate with cetuximab monotherapy. And also, an additional pooled analysis of several prospective trials that was performed in 2013 showed that, even when you broke it down by the exact KRAS mutant allele, you really don't see a significant difference where you see one particular allele, including G13D, that is deriving more benefit from adding panitumumab to control as opposed to not adding it. So there really is no role for the addition of anti-EGFR therapy to a codon 13 mutant KRAS patient at this time. However, as we're all aware, mutations occur not only in codons 12 and 13 of KRAS, but can occur in a variety of other sites. So these are just diagrams demonstrating the frequency of mutations present at particular alleles within KRAS or its homolog NRAS. And you can see, although these other mutations are certainly less common, they certainly are not completely rare either. You can see that when you account for these kind of expanded RAS mutations, which I'll define going forward as patients who had mutations within KRAS but not necessarily in the most common codons 12 and 13, that 16% of patients who would have been deemed as wild type in KRAS on the basis of not having a mutation in codon 12 or 13 do have one of these expanded RAS mutations within them. And so there's been another round of studies that have looked back at several of these prospective trials and looked at, broken down the results based on expanded RAS status. And the data has concluded that these expanded RAS mutations are also a negative predictive biomarker for anti-EGFR antibody therapy. So this is from the PRIME study, which looked at FOLFOX versus FOLFOX plus panitumumab and looked specifically at the relatively small number of patients who did have one of these expanded RAS mutations, but were wild type in exon 2, specifically of KRAS. And among these, you can actually see that there is no significant difference with the addition of panitumumab. If anything, there's a trend towards the FOLFOX without panitumumab, trending towards a better progression-free survival, although certainly not significant. Additional meta-analyses of several first-line trials or other trials of looking at the expanded RAS status have shown that this expanded RAS group does significantly worse with the addition of anti-EGFR therapy than the all-RAS wild-type group in both overall survival and progression-free survival. And then when you compare this expanded RAS group against the kind of traditional definition of KRAS exon 2 mutation, you can see that there is no significant difference between these two groups either by overall survival or progression-free survival. So that's really led to the current standard definition of what we would define as a RAS mutation, where guidelines have called for testing specifically within codons 12, 13, this is a typo, 12, 13, 59, 61, 117, and 146. And our understanding of what defines a KRAS or a RAS mutation that is a predictive biomarker against the efficacy of anti-EGFR therapies has evolved from just KRAS exon 2 to all this expanded RAS definition. Now, I really do want to point this out and urge you to really pay attention to how you're testing for RAS and what your standard panel is and if it actually includes all of these loci. We're all aware that there are side effects and toxicities of anti-EGFR therapy, and so we don't want to expose patients who are very unlikely or not going to receive any benefit from these therapies to the risk of getting and toxicity of getting an ineffective therapy. So with that kind of underlying discussion, that's led to several trials asking the question of is there an optimal first-line regimen, specifically is it better to add bevacizumab or an anti-EGFR antibody to a chemotherapy backbone in the first-line setting for these RAS wild-type colorectal cancers? And even this is kind of been a story that's been evolving over the last 3 years or so. So the 80405 trial performed within the United States showed that when you looked at all comers, there was no significant difference between bevacizumab versus cetuximab added to the treating investigator's choice of FOLFOX or FOLFIRI in patients who had a RAS wild-type cancer. Initially, this was restricted only to KRAS codon 12 and 13 wild type, but this also holds true even in those with the expanded RAS definition. And for a while, we were all puzzling over how to compare the results of 80405 against this trial out of Europe, the FIRE3 trial, which actually showed that there was a significant survival benefit in favor of adding cetuximab to FOLFIRI first line as compared to adding bevacizumab to FOLFIRI. Now this was really limited to the overall survival. So up top you can see that there was no improvement, or sorry, on the left side you see that there was no improvement in progression-free survival among patients who received cetuximab-based therapy versus bevacizumab-based therapy by either of these RAS definitions. But there was a significant improvement in overall survival when you looked at patients who got first-line cetuximab versus first-line bevacizumab. That was true even in the old definition of KRAS mutation, and even more so among the expanded RAS definition. And this just points out that similar first-line trials of panitumumab-based therapies in the first line have shown similar outcomes, where you see that there was a survival benefit in favor of adding panitumumab to FOLFOX as opposed to bevacizumab to FOLFOX. So for a while, it was difficult to try to reconcile the results of these studies. And what's emerged within the last couple of years really is that there's a significant effect of the primary site of the tumor and the degree of efficacy of anti-EGFR therapy. So in all my slides moving forward, I'm going to define the right colon and the left colon. Right colon being defined as cecum, ascending colon, hepatic flexure, and arguably in some studies versus others, the transverse colon. I think most of us would probably lump transverse colon more towards the right colon. The left colon is defined as a splenic flexure, including points distally all the way through the rectum. So we've known for a while, actually, that having a right-sided primary colorectal cancer is a negative prognostic biomarker. So when you look at results from a number of first-line clinical trials, this is kind of a meta-analysis that shows that patients who had, regardless of their treatment really, who had a right-sided colon cancer had worse survival than patients who had left-sided colon cancer. So, and we see that kind of recapitulated in this handful of studies that I've just talked about as well. So in the 80405 trial, as was presented at ASCO a couple of years ago, we actually saw that there was a significantly worse overall survival among patients who had right-sided primary tumors as compared to patients who had left-sided primary tumors among those who received cetuximab. So here you can see that the median overall survival for patients who had a right-sided primaries who received cetuximab plus chemotherapy was only 13 to 14 months versus over 39 months for patients who had left-sided primaries who received cetuximab-based therapy. And you can really see, again, just based on these Kaplan-Meier curves and this comparison here, that when you look at among patients who had a left-sided primary tumor, there was actually a significant improvement in overall survival with getting cetuximab first line as opposed to bevacizumab first line. Among patients who had a right-sided primary, there was actually a significant worsening of overall survival among patients who got cetuximab first line as opposed to bevacizumab first line. I'm sorry, I shouldn't say it's statistically significant, probably based on the smaller number of patients you see, but you can see the degree of separation of these curves, and looking back at the survival numbers, you can actually just see how marked the survival difference is of a median 13 months versus 29 months among patients who had a right-sided primary. And there was, in fact, a significant p-value for interaction between left versus right-sided primary and the treatment. And this is held true even with kind of accounting for expanded RAS testing and BRAF testing. So we can see here that, that when you factor in the patients who had expanded, were wild type and expanded RAS and also lacked a BRAF mutation, that you can still see some of these differences. Now the statistical significance may be changed kind of, but you can actually see that getting cetuximab, the group that actually did the best is the group who had left-sided primaries who got cetuximab-based therapy first line, and the group that did worst is the patients who had a right-sided primary who got cetuximab first line. And this is not a small difference. This is a matter of 18 months versus 40 months. The other thing I'll point out is that across the board, patients who did harbor a BRAF mutation just generally had worse survival compared to those who did not have these BRAF mutations, and I'll get to that a bit more in a little bit. But you can see just how poor those survival was, in particular for those patients who got cetuximab-based therapy. We can see that there have been several subsequent studies that have looked at a number of trials, including looking at the Crystal trial and the FIRE3 trial, which actually have also shown similar trends. And it looks more like perhaps you saw some of these differences between FIRE3 and 80405 because there was actually a differential ratio of patients who had a right-sided versus left-sided primary. And looking at kind of those trials, 80405, FIRE3, and the smaller PEAK trial, again, we see the same trends where patients who had a right-sided primary who got cetuximab-based therapy first line had the worst overall survival, and patients who got left-sided who got cetuximab tended to have the best overall survival, although the difference is probably starkest between the choice of treatment among those who had right-sided primaries. This just points out again that we can see some of these significant differences in right versus left across treatment arms. And you see some of these differences to a statistically significant level based on choice of treatment among left-sided in particular. So the conclusions for that have been kind of distilled into the NCCN consensus guidelines really has been, again, recap. We should be confirming that patients are, in fact, wild-type and extended RAS. Make sure that your panels include that. We do not recommend use of anti-EGFR-based therapies for patients who have a right-sided primary cancer. For patients who have a left-sided primary cancer, there's not necessarily one right or wrong answer. The studies that I've shown do show that you do get a better overall survival with first-line anti-EGFR therapy, although the difference is not quite as stark. And so it is certainly reasonable to consider bevacizumab-based first-line therapy based on a discussion and consideration of the side effect profiles of these drugs. And again, as you saw, the BRAF mutant patients did have pretty poor outcomes, and so I think about different strategies for those patients, which I'll get to in a second. And that's just to point out quickly that primary side is really a clinical surrogate for a range of biologic differences. I've alluded to the facts that right-sided primary colon cancers are much more likely to, say, have the hypermethylator epigenetic phenotype as opposed to the chromosomal instability phenotype, have higher rates of BRAF mutation, etc. And I'm just going to briefly touch on the fact that we also see differential rates of various gene expression-based subtypes, these consensus molecular subtypes. And this may be an emerging potential biomarker as well. This is certainly not prime time, not being done in the scope of current clinical practice, but there's been a lot of high-profile studies about this, and so I did want to just at least mention these subtypes. And these subtypes are clearly prognostic. From the 80405 study, we see that patients who had the most conventional gene expression profile of CMS2 had the best outcome in terms of overall survival, and those who had the CMS1 type, which is actually generally microsatellite high, had the worst outcome. And you can see similar impacts as a potential predictive biomarker for CMS1, gauging cetuximab versus bevacizumab. So, to be determined, to what extent this enters routine clinical practice, but I do think this is an important consideration of the biology. To touch briefly on BRAF mutations, we know that 5 to 11% of colorectal cancers have mutations in BRAF. By far, the most common codon that is mutated is the V600 codon. This is a biomarker of very poor prognosis. And we've known that since the late 2000s, early 2010s. As seen here, you can see just the stark difference in overall survival from this paper out of MD Anderson, and that's been recapitulated over and over again. So this is data from the 80405 study that also has shown that BRAF mutations conferred a worse prognosis. We're starting to get into more kinds of novel biomarkers, so I'm going to touch very quickly on these, and we'll welcome any questions at the end. But I do want to point out, if you do order next generation sequencing, since the Foundation 1 CDX was recently approved by CMS, You may end up getting a handful of other mutations and genomic aberrations, and you may, I think we're all in the situation trying to figure out what to do with them. Are any of them actionable? And I just want to point out a couple of highlights that I think have piqued my interest, even though these are admittedly quite rare. So number one, there are other BRAF mutations other than codon 600 as well. I think data is emerging on the best way to approach BRAF codon 600 mutants and other BRAF mutations. There are ongoing studies looking at the role of hitting the EGFR and its downstream signaling cascade at multiple levels. So, for example, this paper from earlier this year commented on the role of an EGFR antibody plus a MEK and BRAF inhibitor, and did show a 21% response rate, and there are ongoing clinical trials in this setting. However, I will caution that BRAF inhibitor monotherapy is very clearly not effective in colorectal cancer, so I would not seek that. If you're looking for a clinical trial, but unfortunately cannot find one, or it's just not feasible for a patient, there is evidence for the use of off-label vemurafenib, BRAF inhibitor, plus cetuximab plus irinotecan in patients who have not received prior anti-EGFR therapy. And that was based on this phase 2 trial that was done that randomized patients to cetuximab irinotecan plus or minus vemurafenib. And you can see progression-free survival was significantly better among patients who had the addition of vemurafenib. Median survival was not significantly different, although that was probably diluted by the fact that there was crossover. Now this, again, is not an FDA-approved indication, but because of limited options and because we know the limited utility of anti-EGFR therapy alone, as we saw from some of the data from 80405 and other studies, this actually is included now in the NCCN guidelines as something you can consider. Just to highlight that, as I was mentioning before, that BRAF mutations are not all equivalent. The most common mutation that's not a codon 600 mutation is probably this 594 mutation. They have different effects on activity, and there's actually some evidence that some of these codon mutations actually result in an increased dependence on receptor signaling. And we also know that not all BRAF mutations confer the same stark prognosis as a BRAF codon 600 mutation. So I do just want to point that out. HER2 amplification also appears likely targetable based on preliminary clinical trials. Trastuzumab monotherapy has not been particularly effective, but there's more promising preliminary data from the Heracles trial of trastuzumab plus the small molecule inhibitor lapatinib, as shown on the left, and dual antibody therapy of trastuzumab plus pertuzumab, as seen on the right. Again, these are not FDA approved at this time, but there are ongoing cooperative group clinical trials seeking to really establish a rigorous evidence base supporting the use of anti-HER2 therapies in colorectal cancers. I do want to just point out that you do not want to miss a potentially actionable gene fusion in colorectal cancer. These are very rare. Individually fusions in NTRK or ALK or ROS1 are less than 1% of colorectal cancer patients, but I think particularly given the very promising data for these NTRK inhibitors, such as larotrectinib, pointed out here are the colorectal cancer patients, and you can see some of them really had a very pronounced response. So I do think that that is something you would not want to miss in your next generation sequencing report if you've got this. These fusions are more common among patients who are RAS wild type, MSI-High, and have a right-sided primary. And speaking about MSI-High, that really leads us to the question, as I was alluding to before, about the role of immunotherapy. And we clearly know that immune checkpoint inhibitors have activity and are now FDA approved. So on the left here was the seminal results from the KEYNOTE-16 trial that looked at pembrolizumab and MSI-High cancers, including many colorectal cancers. You can see that many patients not only had a response, but had a durable response similar to the efficacy of checkpoint inhibitors and some other very checkpoint inhibitor sensitive malignancies. And consequently, pembrolizumab hasn't been approved by the FDA for MSI-High solid tumors, kind of agnostic of the primary site, although certainly in consideration for colorectal cancers after failure of other standard chemotherapies. There's a similar evidence base for nivolumab based on the Checkmate 142 trial, which showed a median overall survival at 1 year of nearly 3/4 and a median progression-free survival of over 14 months, with nearly half the patients continuing to remain progression-free for longer durations of time. So nivolumab has also similarly been approved by the FDA for MSI-High colorectal cancers. And within the last couple of weeks, the FDA approved ipilimumab as well in conjunction with nivolumab. The dosing scheme is shown up here with 4 doses of ipilimumab plus nivolumab, followed by nivolumab maintenance afterwards. You can actually see that the 1 year overall survival is now up to 85% with this regimen. And subgroup analyses really have shown benefits even in patients who had BRAF mutations, which often tend to have MSI-High tumors as well, regardless of PD-L1 expression, which is why this is not a useful biomarker. So, and whether or not you had Lynch syndrome versus sporadic MSI-High based on kind of MLH1 hypermethylation. Now, there's ongoing questions of how to best approach and treat these newly diagnosed MSI-High colorectal cancers. This is a question that remains to be determined. There are a couple of phase 3 trials that are ongoing that recently started enrolling, and so I think it's going to be a while until we find out, is it chemotherapy alone, immune checkpoint inhibitor alone, or chemotherapy plus immunotherapy, and now how do we factor in ipilimumab to the mix? Using immuno-oncology and microsatellite stable colorectal cancers has been an enigma, and I think is one of the key priorities to try to learn more about. I do think among microsatellite stable colorectal cancers, you probably do not want to miss the hypermutated POLE mutant patient. There are case reports that POLE mutant cancers may respond to pembrolizumab, which makes sense because of the high mutational burden and neoantigen burden. But unfortunately, there was a recent large phase 3 trial of a PD-L1 antibody, atezolizumab, plus the MEK inhibitor cobimetinib, and despite very encouraging, very early phase 1-2 data, panned out with a negative phase 3 trial. And really the key question has been how to find novel combinations of therapies to increase the lymphocytic infiltration to these immune deserts, which comprise the majority of microsatellite stable colorectal cancers. There are consensus guidelines that have been pointed out on molecular testing that were published recently. Again, expanded RAS testing, as I've stressed several times. These guidelines do recommend testing for the BRAF V600 mutation, at the very least for prognostic stratification, because it is such a poor risk group of patients. As I mentioned earlier, it may make me think about even more aggressive first-line therapies up front. It may make me look for other targeted clinical trial approaches. Testing for mismatch repair status, not only to identify patients who should be seen for genetics evaluation for Lynch syndrome. It can provide prognostic stratification, primarily in patients who are not stage 4, more particularly stage 2. But at this point, since the guidelines were published, clearly MSI-High is a predictive biomarker for immune checkpoint inhibitors, and so I added that kind of to there. And I do want to point out that you don't have to re-biopsy patients. It is acceptable to use archival primary tumor tissue. And this is just a summary of some of the kind of non-standard options. Again, none of these are FDA approved, although the cetuximab and niraparib irinotecan option for BRAF codon 600 mutant patients is in the NCCN guidelines. These others are still in the midst of clinical trials. Hopefully, in a couple of years, we will be able to update this and say that there are new options for patients with these subgroups and with these biomarkers. And with that, I want to conclude and welcome any questions.
All right, Dr. Lee, thank you so much. This has been great. Because we are running low on time, what I'm going to do is, we don't have any questions in yet, but we'll allow a few minutes for questions. And while we're waiting for those questions to come in, and just as a reminder, if you hadn't joined Poll Everywhere earlier, you can go ahead, pollev.com/UNCCN, or text to the number 22333, the letters UNCCN, to join one time, and then send in your question. I'm going to go over some of our closing remarks, and then then I'll come back to the Q&A part of Poll Everywhere, and we'll see what we've got. We do want to thank everyone for attending. We always appreciate all of our audience members. Thank you for being here. Thank you for spreading the word about these free lectures, 4-credit lectures, which can be viewed both live, like we're viewing them today, or in our learning portal. We want to thank the generous support of the North Carolina General Assembly, for the UCRF, that's the University Cancer Research Fund, the UNC Lineberger Comprehensive Cancer Center. We also want to thank our team, Mary King, Veneranda Obore, and John Powell, for all of their hard work to make this and every lecture possible. Upcoming, we have an RN and Allied Health lecture, August 8th at noon. That's Survivorship Care Planning Beyond Standard 3.3 with Dr. Deb Mayer. And then we've got August 22nd, a Med-Surg oncology lecture, Recent Advances on the Gut Microbiome and Cancer Therapy with Dr. Keku. So we hope you'll be available to attend both of those. Our self-paced online courses, you can go to learn.unccn.org, find our learning portal, take these free for up to a year after they've been presented. We now have available medical marijuana. It's high time to talk with Dr. Benner, and update on the diagnostic and therapeutic advances of acute myeloid leukemia with Dr. Zeidner. So we hope that you'll visit our portal and be able to take both of those courses, as well as the many others that are there. With that, and also mentioning, you can always find out a wealth of information at our site, unccn.org, upcoming lectures, past lectures, our library of over 200 lectures in all. And of course, we're on YouTube and other places I mentioned as well. And I'm glad to see a question. Are there options for clinicians to include their patients in clinical trials without the patient having to personally present to UNC?
Well, we always are happy to discuss whether a patient may be a trial candidate. First I want to, our GI group does, have a list of ongoing, currently accruing clinical trials. So if anyone actually is interested in receiving that, we're happy to share that with you. You can actually email me. Is my email address included?
I don't think that we posted it. Anyone who just emails us at UNCCN at unc.edu, so UNCCN at unc.edu, we'll go ahead and forward that on to Dr. Lee.
So we'd be happy to kind of circulate our list of currently enrolling clinical trials. Every trial, as you're aware, has a whole list of inclusion and exclusion criteria, so we don't want patients to spend their time and, energy getting up here if they're very clearly not going to be a candidate for a particular trial. So we're happy to start screening, like a cursory screening in advance. Most clinical trials, if they actually are going to come, though, are going to require some degree of time coming and going here, because we do have to be sure that we are monitoring them very carefully for any potential side effects or toxicities on the trial, and we get held to a high standard by that as well. And so most of the time patients will actually have to personally present if they're actually going to be enroll in the trial and then proceed on the trial.
All right. Well, thank you so much. If there are no other questions today, as mentioned, you can forward those questions on through our team at unccn at unc.edu. Again, please spread the word about these lectures. They're free. They're 4 credit, both live and in the self-paced version on the portal. So thank you again to all of you for being here today. Dr. Lee, thank you so much. It's been a pleasure to have you today. And we'll see you all at the next lecture. Thanks so much.
Thanks.